In this AMA podcast, we answer important questions like, will DHEA make you go bald? How do we feel about scrotal cooling? And how to cut onions without crying? Stay tuned. Welcome back to the Gillett Health podcast. My name is James O'Hara, and I'm a nurse practitioner. Today is a solo episode. We're going to be doing an AMA. So our media guy has pulled some comments from recent YouTube videos, Instagram. I don't really know where they came from, but I have them in front of me, and we're going to go through some of those questions. Up first, can you combine dutasteride mesotherapy with PRP? So in a sense of using both of these treatments for stimulating scalp hair growth, they can be used. Whether you would combine those in the same, say, syringe that you're injecting, I don't know that that has been done clinically and with results published. I would guess it's probably okay to combine those in the same syringe, but I would err on the side of caution and would inject those separately if I were performing this on a patient, just because you don't want to give someone a treatment where something is interfering with something else. For example, if, let's say, hypothetically, the dutasteride makes the PRP less effective, something like that is possible. Doubtful that that would be the case, but I would err on the side of caution there. But you can absolutely do these in combination, and there's probably going to be some synergy there because you're limiting the androgens and sending growth factors, so you probably see faster improvement. Up next, Mr. Big Harv says, so testosterone can be injected subq in the glute. Yes, that is correct. Testosterone, testosterone can both be administered subcutaneously. Probably best to use new syringes, insulin syringes, to do this if you're used to doing the intramuscular injections. But you could administer it in the love handles, about an inch away from the belly button in either direction or below the belly button. The subcutaneous fat in the glute, depending on how lean you are, the middle outer third of the thigh. You can administer there if you have some subcutaneous fat there. James, do you inject subq? And if so, which Esther do you prefer? So yes, I inject subcutaneously Monday, Wednesday, Friday. I don't really worry about having 2 days between injections on the weekend. And I don't have a preference, cypionate and anthate. Personally, I don't notice any difference. I've tried both of them. Body weight, fluid retention, everything seemed to be about the same. So no preference on Esther, but strong preference for subcutaneous injection. Next, someone says, is statins dangerous? Generally, no. However, there are things to watch for. Probably the most dangerous side effect or side effects, one would be liver failure, extremely rare. The other, rhabdo, also extremely rare. In both cases, you will have a pretty obvious sign that this is happening. In the former, you will have very dark colored urine and probably will not be feeling very well. A profound loss of appetite, some abdominal pain perhaps. In the latter, you will have pretty profound muscle pain and also very dark urine, like Coca-Cola, very brown, dark urine. And it's not something that's going to sneak up on you. Now, those are very rare. Probably 5% of people have some muscle aches. There are people who will tell you that statins are toxic and that 0 people should ever take them. That's not my view. So we've talked pretty extensively about statins on the podcast, so perhaps we can link to some of those episodes and talk through statins and dementia or the such. And if there's ideas or specific questions about statins that you all have, just drop those things in the comments below. So can women use MK677? Not anymore, because the FDA has labeled this as a Category 2 503A substance, meaning it may pose significant safety risks despite studies showing generally good efficacy in things like improving lean body mass and bone mineral density. However, they stated this due to one study which showed a safety signal concern towards congestive heart failure. Not a huge surprise. Growth hormone can drive fluid retention. And if you have a elderly population, you could probably see some sort of breakthrough there where this is the trigger for the onset of an exacerbation of heart failure, or perhaps it wasn't diagnosed at baseline. So as far as safety profile, there's a list of pros and cons to go through. Side effects, yes, fluid retention, insulin resistance. Out of all of the growth hormone secretagogues, this is the one I have seen people come to me taking and their blood work showing A1Cs that have increased, in A1Cs that have perhaps increased even to the pre-diabetic or diabetic range. It seems to have a pretty strong effect on appetite. So there definitely are side effects. It used to be able to be used, and perhaps there are some pharmacies still making it. But to my knowledge, all of the trusted compounding pharmacies have stopped making it. Maybe there's some smaller ones out there that still are. What's your view on scrotal cooling? So potentially helpful for fertility, not specifically studied for improving testosterone. I've heard it mentioned and recommended that if someone is going to be saunaing, that they use a cool pack. I don't know that that's necessary outside of a fertility context. In a fertility context, we'll often recommend people to either discontinue sauna use or to use scrotal cooling when they enter a sauna, to discontinue hot tub use. Might as well skip the heated seats in the vehicle as well, because several degrees below your body temperature is actually the optimal temperature for the testes as it relates to sperm production and testosterone production as well. So on a video entitled, "Can DHEA Boost Your Testosterone?" SD Motorsports says, "So will this make me go bald through making extra DHT? I'm currently on Dutasteride for hair loss." They abbreviated Dutasteride as Duta. Probably not. The Dutasteride should be more potent, should be stronger than the DHT you get from DHEA. I don't think you'd see a meaningful increase in serum DHT. If I'm playing devil's advocate, I could say that if you're extremely sensitive to DHT and perhaps there's some paracrine effect of DHEA where it goes into the tissue and converts to testosterone and then to DHT, maybe the Dutasteride isn't fully going to block that. But in general, the Dutasteride should be more potent. I would be more worried about excess estradiol from the DHEA while taking the Dutasteride, shifting the balance of estrogens to androgens. Megan Rose 5955 says, "Yeah, not trusting two random dudes yammering on about a female-targeted pharmaceutical." I believe this was in response to our discussion on Addyi, medication for hypoactive sexual desire disorder. As it turns out, I am relatively gender agnostic when it comes to medications and their mechanism of action. I will prescribe Dutasteride for females when appropriate because females have DHT just like men do, and it can cause hair loss. And just like women, men have 5-HT2A and 5-HT1A receptors, which Addyi works on. Next, Cotton Socks 2405 says, "Well, sorry, don't believe you. I know many people that had perfect periods and fertility, and after stopping the depot, they had erratic periods and then diagnosed with PCOS." So a little bit to unpack there, and this one is kind of confusing to me because if you are taking the depot shot or any form of contraception, the idea is you're not going to have perfect fertility, that you are preventing fertility and preventing conception. So I believe that's all I'll comment on that one. I'm definitely not convinced seed oils are inflammatory and poisonous to health, but is it bad at all for androgens in any aspect? So bad for androgens in any aspect? I wouldn't say it's bad. There's a sliver of data that suggests it might be less good than saturated fats. If you're looking at polyunsaturated fatty acids versus saturated fatty acids, the saturated fat might have a slight edge in upregulating some of the enzymes that are involved in testosterone production, but it's probably not going to be a significant enough effect. And it's something that if you're trialing, you will certainly want to monitor your ApoB levels, testosterone levels. And I wouldn't think it's the sole reason that someone would have a suboptimal androgen pool. What hormones should I check before hopping on Dutasteride? So looking at your sex hormones like total testosterone, free testosterone, my recommendation is to get a sex hormone binding globulin and calculate this yourself. If you use the equilibrium dialysis assay through LabCorp, it will, from what I've seen, 100% of cases overestimate your free testosterone. And their direct free testosterone assay tends to be sort of all over the place. So a calculated free testosterone is what's going to give you the repeatability there if you're testing things downstream. A lot of people will say to check a serum DHT. I'm pretty neutral there. The DHT level per se doesn't drive hair loss, linearly across individuals. It's more so the sensitivity to the DHT. But if you like and you want to monitor the change, you can check a pre and post DHT level. Other things to look at would be prolactin, estradiol. Those are things that could predict how likely you are, or if you're less likely to develop side effects like nipple sensitivity or gynecomastia. So those are sort of the basics that come to mind. But in reality, I recommend just if you're routinely getting blood work, like we sell very cheap on our website, you can get comprehensive panels, maybe once a year, twice a year, depending on where you're at in your health journey. And that would capture sort of and check all of the boxes you'd want to make sure are intact before you would start something like Dutasteride. Does Gillett Health offer TRT, trend replacement therapy? Answer to the first question is no. The next part says, I'm an older Aberdeen Angus, and I'm worried my feed efficiency just isn't what it used to be. So this is an incredibly clever comment. I do really appreciate this. At this time, we do not accept Angus or animals of any sort in our practice. In the future, we may add a veterinarian and help those cattle in dire need of improved feed efficiency. Hey, Dr. Gillett. I'm not Dr. Gillett, but I'm going to read this. My ARCAG repeat is 24. Will I be less sensitive to androgens? So this also depends on, I believe, GGN repeats, but directionally you would think on average, perhaps you are slightly less sensitive to androgens, which might bode well for risk of cardiovascular disease, risk of prostate cancer, but it's probably not enough to make a clinically meaningful difference. And it's not something I would necessarily think about for reference myself. I believe I have 28 repeats, so in theory, I'm less sensitive to androgens as well, but it's not something I think about day to day. So what is the long-term Tadalfil use answer? Can I or can't I? So the answer is, it depends. If you are a older male, let's say you're 65 and you have an enlarged prostate, then Tadalfil, daily use, low dose, is approved for treating symptoms of an enlarged prostate. And it may have some other health promoting benefits. It's a bit early to say, but I'm a little optimistic based on the data that's out there. If you are an older male who has unstable angina, you have chest pain all the time, maybe you've got a stent or two in, then taking long-term Tadalfil, probably not a great idea, because if you were in a situation needing to administer nitrates or intravenous nitroglycerin, if you're having chest pain that won't go away, then having the Tadalfil in your system can cause a substantial drop in blood pressure. At James, to avoid crying from cutting onions, cool them in the fridge before cutting. Thank you for the tip. I don't remember. We must have discussed some cutting onions on the podcast at some point, but I will have to give that a try. Or just buy them pre-cut. For your fertility phase, why not switch to Finasteride and go ahead and take a full dose or higher? The half-life is so short, and you can stop Finasteride just a few days before conception. The problem here would lie in that it takes more than just a few days for sperm to fully mature and complete their life cycle. That's realistically going to be something like 50 to 90 days, depending on the study that you're looking at. So you would want to, probably for a period of time a little bit longer than that, not have a 5-alpha reductase inhibitor in your system affecting DHT levels if you want sperm that are exposed to normal amounts of DHT and androgen during their development and at the time of conception. So this comment is correct in that technically at conception you would have normal DHT levels, but during the development of the sperm you wouldn't have normal exposure to DHT of all of those developing sperm. Given how quickly enclomiphene is eliminated from the body compared to Clomid, wouldn't this lead to a lot less side effects if a man's goal is to increase testosterone and preserve fertility? I suppose the question is in relation to what? If it's instead of testosterone, perhaps in the short term, there would be less side effects. If it's compared to HCG or Pregnol, then I don't think that's the case unless you perhaps are using injection site pain as a side effect. My concern around both Clomid and enclomiphene is the depriving tissues of estrogen and the agonizing of the estrogen receptor in other tissues. So, for example, in the ocular tissue, in the eyes, you're going to antagonize estrogen receptors. This is the mechanism of these medications, basically. They are going to antagonize estrogen receptors in the hypothalamus and essentially increase LH and FSH, sort of trick the body into thinking there's low estrogen for men. And then as a male, you get your estradiol from aromatization from testosterone. So your body ramps up testosterone production. With the agonism of estrogen receptors, particularly in the liver, you may see a shift towards a more hypercoagulable state. So being a SERM or selective estrogen receptor modulator, enclomiphene still does have some risk of provoking blood clots, DVT, pulmonary embolism, particularly since about 10% of men are going to have, they're going to be a carrier for a factor 5. It's not something routinely tested for. So I tend to stay away from either of these for long-term use. Short-term for fertility, they can have a favorable risk-benefit profile, particularly because of the cost. But if I was picking what would I like the new medication to be that's an alternative to Clomid, an alternative to enclomiphene, an alternative to HCG, it would really be an orally bioavailable or sublingual form of HCG, or perhaps a specific LH receptor agonist. To my knowledge, there's only one of these that has been studied preclinically, shown to improve testosterone production. So maybe we'll get there at some point in time. But right now, my preferred pharmaceutical test booster is Pregnol, which is very specific for directly increasing testosterone production. It doesn't work as far upstream as something like Clomid or enclomiphene. Hey, thanks for all the great info you share. I love it. I have a quick question for you after listening to the Just the Basics TRT episode. You referred to thick blood pretty often, so I was curious what the hemoglobin and hematocrit levels would need to be considered thick. My hemoglobin is 18.7 and my hematocrit is 54.6. So the threshold, if you look at the package insert, would be 54%. A lot of the recommendations and the guidelines would say to discontinue or lower the dose if you reach a threshold of 54%. One paper does show an increase above 52% being slightly associated with an increased risk of DVT or venous thromboembolism. Again, your background risk here in these higher risk populations is quite low. It may be around 5% in that first year of testosterone, maybe a percent higher than that if you are in a group that has a hematocrit above 52, 54. So in that general ballpark, maybe it's 4% and then your risk goes up to 5%. So that's the risk you're looking at. Typically, we'll look at, what are the potential causes here? Does somebody develop a sleep apnea, or perhaps they had a sleep apnea beforehand? If you are living in Denver, Colorado, and this is your hematocrit and hemoglobin, this is more likely hemoconcentration rather than an increase in plasma volume. So there's a lot of things to look at there. Perhaps if you're taking medications that can increase red blood cell count, like SGLT2 inhibitors, or if you are injecting EPO as part of your performance enhancing drug stack, probably stop that. But what I would do is most likely start with a sleep study, specifically because we know testosterone can trigger this. And you can't tell if someone has sleep apnea just by looking at them. If the total and free testosterone levels are off the charts high, perhaps trialing a dose reduction makes sense. And depending on ferritin levels, where your iron stores are at, it might make sense to do a blood donation. But that's something to have a discussion with your provider about. All right, well, that concludes our AMA installment. I hope you enjoyed this. Let us know in the comments if you have more questions. Let us know in the comments if you didn't enjoy the answers. And as always, thank you for your time. May God bless you with health and happiness.